And Scott is going to tell us a little bit about a book that he wrote called Relationship Matters. So why don't you
take her away? Thanks.
Take her away.
Good morning. Charlie, that might be a titch loud for me. Scott Jensen here. It's great to be here. My wife, hey, would you stand up, please? My better half. We've been married 40 years. Thanks. What I want to talk about today is now about my book. Thanks so much. I want to talk about, this is a cup from Alcatraz. Thanks, Brian. Appreciate it. That's really good. I want to talk about something that I'm passionate about, and that's trying to help people get the health care they need and they want. The system's changing a lot. And if we go back, let's just go back to when my dad was born. My dad was born at that time, the average amount of people spent on their health care in a given year was $20 a year. Today it's $11,000. Things have changed drastically. We have a tendency in our society today to make everybody sort of fit into one cookie cutter kind of shape, and that doesn't work because everybody's got different perspectives and different wants and people should be able to champion their own health care. They should be able to decide whether or not they want to take this flu shot or whether or not they want to take this statin drug for their cholesterol. So the book is a piece because 2 years ago we released the book, and it's called Relationship Matters, and it's 33 chapters representing the first 33 years of my medical career. And each chapter deals with a patient story, and it's a true story. I didn't really embellish or elaborate because when you're dealing with people, you don't have to. They're as bizarre as you need them to be to write a book. But before we start that, maybe what we should do is just shift gears a little bit and talk about the weather. So Lowell was in 2 days ago, and he told me a story. He's a huge man. He makes Pillsbury Doughboy look slender. He's in his 80s, and he still farms a little bit. And he grew up on a farm. And he told me about a shirt-tail cousin of his who died quite a few years ago in the middle of a blizzard in the Dakotas. And you're wondering, why did his shirt-tail cousin die, and why am I telling this story? Because his cousin made a mistake. His wife told him, don't go out to the barn, it's a raging blizzard, you can't see in front of your face. And he says, don't worry about it, honey. I got a rope tied from the back of the house to the barn so I can get back. And he did. And he went out not to feed the livestock, he went out to feed his cats. And he never made it back. He lost grip of the rope, he wandered, snow covered him. He wasn't found till 2 months later when the snow's melted. And he was about 100 yards off of the rope. The blizzard was blinding, it disoriented him, and it cost him dearly. It's no different today in healthcare. You've got your own blizzard you're dealing with. You're dealing with fibs and fabrications, you're dealing with fake news, you're dealing with frank falsehoods, and you're dealing with feelings that are fragile and you've never had them before. You don't know how to sort it out. The American Heart Association met the other day. They came out and they said, voila, after years and years of study, we've learned now that fish oil does not reduce cancer, does not reduce heart attack risk, and the fact of the matter, it increases your risk of prostate cancer. They came out and said vitamin D is not doing the things that it said to do, and there's no reason to take all these supplements. But then toward the end of the article, they talked about a new drug called Vascepa. And they said, this might be the one. This is fish oil repackaged. Instead of having you take 1 gram a day, we're going to have you take 4 grams a day. And it looks like there might be a slight reduction in your risk of heart attack and stroke. But then they went on to say that the data wasn't certain, because when they did this study on Vascepa, for the placebo comparison trial, they used mineral oil. And all the patients they were studying were already on a statin drug like Lipitor. And mineral oil reduces the ability for the statin drug to do what it's supposed to do. So in other words, they put Vascepa up against mineral oil, knowing that any potential beneficial effect from the statin drug would be mitigated by the mineral oil. And they had the gall to say that we maybe should go out and spend $10 a day for this 4 grams of fish oil that they just came out and said isn't effective. How do you sort through that? If I tell you that a test for a rare disease, let's say Guillain-Barré, has a 5% false positivity rate, there's a tendency on your part and the part of physicians to say, shoot a mile. 5% false positivity rate, that must mean that if the test, it's 95% reliable. What does that mean? That means that if I tell you that your test is positive for Guillain-Barré, you're going to take it to the bank. Gee, I've got Guillain-Barré. But the fact of the matter is, if it's a rare enough disease, which Guillain-Barré is, it happens in less than 1 in 1,000 patients. But let's just say it happens in 1 in 1,000. A 5% false positivity rate will give you 50 people out of those 1,000 will get a false positive rate. And there'll be 1 person out of 1,000 that'll have it, so that'll be the one true positive. So put the true positive with the false positives, you now have 51 people out of 1,000 people are being tested and are all coming back. They've got Guillain-Barré. But the fact of the matter is only one of them has it. So when we tell you that information, we're giving you the impression that we're 95% reliable, but the fact of the matter is we're 2% reliable. How do you sort through that? The only way you can do it is to find a good rope that'll get you from the back of the house to the barn. And that's where the relationship matters. You need to build a relationship with a physician or a provider, a nurse practitioner or a PA, but you need to own that. In the same way that you want to have a good relationship with the other key people in your life, whether it's family, whether it's support group, whether it's your mom, your dad, your grandparents, your kids, you need to invest in the same way to make sure you get the health care you want. Because what you want may not be what you want. So let's just take those 4 letters in the word rope. Relate. When you go in and see a provider, don't just dump out 5 problems and fix them. Relate to the person. I mean, if someone comes in and that morning they got an emergency appointment because we had a 10-minute slot, and they told the front desk that, I am coughing up this yellow-brown stuff, and I think I got a problem, and I've got to fly out to Vegas next week. I need to be well. And then you come in with a list of 6 things, and the first 3 are insomnia, anxiety, and depression. What's the likelihood we're going to be able to, crack that puzzle in the first 10 minutes? So relate to the person. And it goes both ways. The physician needs to relate to what you're going through. I mean, if you come in for a cough and it's clear that you've been crying and you're distraught, then I need to check in with you. Hey, Bill, what's up? We'll get to the cough, but what's up? Second letter in the word rope. Own it. Don't blame anyone else. Don't blame Blue Cross. Don't blame the government. The relationship. Say, this is up to me to find the relationship that will work for me. The P, personalize it. I've got this one lady, she's 92 years old, and a little daffy, but not demented, and there's a difference. Meet my in-laws. Just kidding, Mary. Okay. But when she comes in, one of the first things she always does is she says, how are those grandbabies? I mean, her mascara is tilted. She missed on the forehead on the right side, on the left side, the cheeks flared. I mean, she's just a delight. But she doesn't care about her chest pain, her rheumatoid arthritis. She wants to know how my grandbabies are. That gets me on the right foot. So I need to look at her and say, my grandbabies are good. How are your great grandbabies? Personalize it. And then the last thing is really important. The last letter of the word rope, expand it. And that's a two-way street too. Expand the visit. So when I see you, if I see Gary Jackson in the office and we talk about something, and 2 days later I give him a call and say, hey Gary, I just wanted to follow up. How's that doing? Typically what Gary will tell me is, did you see the University of Minnesota basketball team last night? They won. I said, Gary, I was actually not calling about that. I was actually calling about that hangnail you had. What hangnail? Did you see that guy shoot that last field goal? It was a three-pointer. But expand the visit beyond what we just did. Patience too. Expand it. Say, the last time I saw you, you did this or you did this or you did this, and it really helped. Or the last time I saw you, you put me on a Z-Pack, and it didn't do a thing. But when I called back in, you put me on this other drug called Levaquin, and that really seemed to be the magic. I wonder if we should write that on the chart, that Levaquin really works, Z-Pak not so much. Own it. Personalize it. Expand it. That's how you start getting the health care you want. So I wrote a book, and the book was basically Relationship Matters. And I wanted to help people understand that the critical piece of getting good health care is two pieces. It's patients trusting doctors. But the piece that comes before that is doctors advocating for their patients. There's no way I can ask you to trust me if you don't think I'm going to advocate for you. I have to advocate for you. I have to call Blue Cross and say, no, we did that medicine, they all three didn't work. This one did, so you need to meet the standard of care for this patient and authorize it. We have to go to the wall to get an MRI. We're not supposed to do an MRI for your back pain until you've suffered at least 6 weeks. I get that. We're trying to cut down on the number of MRIs. And the fact of the matter is, a good number of you with back pain, if I make you wait 6 weeks, by the time we get there, your back pain will be gone. That's what we're trying to do. This isn't rocket science. But the bottom line, sometimes you come in with back pain, you've only had it for 2 weeks, but you're noticing that your foot is now numb and that the strength is leaving your foot. Then we don't wait 6 weeks. We have to advocate, and when we do, we'll build and grow your trust. I've got a patient who's a little upset with me right now because in his right groin, he's got a florid rash. I saw him about a month ago, and I said, I've not seen this before. I don't think it's an infection, but I want to cover that. So I put him on an antibiotic. And I said, but I'm not sure. And I said, we can see a dermatologist, but I'm afraid that's going to take about a month. So what we'll do is we'll go ahead and make the appointment for the dermatologist now and we'll get in line. But let's try the antibiotic and let's see in 4 days. So I saw him in 4 days. The antibiotic had done nothing. The rash was the same. I asked him if he had any problems with cold sores or anything like that that might be viral in nature, and there was nothing, there were no hits on that question. There was one other thing I'd seen a long time ago, about 20 years ago, on a patient that was it just floored me. And I thought, you could have this thing called pyodermic gangrenosum, but I've only seen 1 or 2 cases, but the treatment would be this, we could do this, or I could send you over to the emergency room. He said, let's do this. So we did that. That didn't work either. Well, now we're getting closer and closer to the time of the dermatologist appointment. I saw the dermatologist, and the dermatologist said, everything Jensen's doing is fine. I don't know what else to do, but we're going to do one more thing, and that's we're going to biopsy it. So they biopsied it. And it does come back that it's a virus similar to what you get with cold sores. Well, he had sort of forgotten that he does occasionally have some sores around his mouth that could represent cold sores. So he says to me, Doc, you missed it. Yeah, I guess I did. Tried my best. I thought that we were pretty clear that you didn't have any herpes viruses that would cause this, but yeah, that's what we're dealing with. And so now we'll get it fixed. No harm, no foul. He's going to get over it because we have a relationship. He knows that I missed this one, but I'm going to be there the next time trying my best again. He trusts me to try. I'll advocate for him. That's owning it. That's how you're going to get the health care that you want. We're not perfect. Most of what we do in medicine is pattern recognition, especially in the area of skin disease. So then we get to the book, Relationship Matters. I would like to offer everybody here a complimentary copy. They'll be outside. My wife will coordinate that. And in terms of payment, I would simply ask that the next time you go out by a food shelf, make a contribution. It's on the food shelf. I'm in politics, and one of my favorite bills coming up this session is we're going to try to get this mobile food shelf program up and running, where we get out to all the areas of outstate, towns of 100 and 200, where they can't really have a physical space for food shelves like we do in the Twin Cities area. But we can get vans moving out so that people that don't have enough food can get them. So if you contribute to that, that'd be great. But when you get a book, there's two chapters that I would particularly draw your attention to, again, relating back to how do you get the health care you want. One is centering on grace and gratitude, and I think that's page 184. And the other one is page 118, which is be careful what you ask for. In the chapter on be careful what you ask for, I use a little parable from a dermatologist in Florida, and I received permission from him, and it's called Mama Bear's Final Illness. And it's something you need to understand about what we do in healthcare. It's all about our default position. If you come in and see us, we're going to intervene. We will intervene till we solve your problem, make you worse, or kill you. But rest assured, it'll be with the best of intentions. They wrote a book a few years ago, and I got it for Christmas. The sad thing for me was I got 2 copies. I didn't think that was really necessary. The title of the book was Doctors Kill Patients, Don't They? I mean, it would have been better for me if I just gotten 1 copy, but the fact that I was getting it from all angles, I went back and did my medical boards all over again. But having said that, you need to be careful. I must spend at least 20% of my day telling people that what they're experiencing is their new normal. I tell patients, you've never been this old before. You've never weighed this much before. You've never exercised this little before. 100 years ago, the average lifespan in America was 50. Today, it's 80. We picked up 30 years. Problem is, those 30 years don't look like we're 22. They look like we're 72. Now, there's a lot of 72-year-old people who live life like they're 52, as well they should. And I have a fair amount of 94-year-olds that still think, they're in their... But I also have a fair amount of people in their 50s that live life like they're in their 90s and are just about ready to chuck it. So really, in the end, to get the health care you want, you need to build a rope. You need to relate. You need to own the relationship. You need to personalize it. You need to expand it. You need to remember that your provider is just like you putting his socks on, her socks on, one at a time. And that through the building constructs of trust and advocacy, you can have what you need. And hopefully my book will give you a few smiles. There's a chapter in there about my brother's suicide. Had he had a rope, I don't think suicide would have happened. I had a chance to build the rope. I failed. That happens. So, having said all of that, I think I'd like to turn the attention now to more of a question and answer, what you would like to do and what you would like to hear about from me. So, thank you for your attention.
So we have a new rule, which is I need to come to you for your question so that we can hear, everyone can hear, and we can also hear for our videotape. So I will watch for your hands.
You mentioned doctors, nurse practitioners. I currently only have a nurse practitioner. It doesn't matter in your eyes. We don't have to have a physician.
That's a great question. That's a great question. Nurse practitioners and PAs, physician assistants, are considered mid-level providers. What that means is not that they're inferior providers by any means. It means they're mid-level. They didn't do a 3 or 4 year residency where they had intensive ICU training and things like that. But if you actually look at my workday, the number of patients I see in the intensive care unit is close to 0. So whether you see me or you see my colleague, Kristen, who's a nurse practitioner, or a PA, we all have the same obligation to you, to advocate for you, to try to build your trust, and to recognize our limitations. Now, my limitations may be different than my nurse practitioner side of me. But because I'm not doing ICU work, there's a good chance that easily what you're experiencing or coming to us for falls within the lines or the guardrails of either of us. So I really don't think the letters after the name matter. I think what matters is the relationship you have, and that the provider you see, whether they're an internist, a cardiologist, a family doc, or a nurse practitioner, is focused on recognizing their limitations. I no longer do obstetrics. So if you're having 9th month, best not to stop by the clinic. Go to the hospital. Okay? Well, that's a funny story, though. I do have one patient that I don't normally try to name my patients' children, but not too long ago, they were driving to the hospital to have their baby, And unfortunately, the labor was moving fast, and this is a dear family to me. And right in front of my wife's veterinary clinic, 5 o'clock in the morning, she's sitting there in the passenger seat, and she looks at her husband. Oh, no, he's here. And she had the baby. And so we were chatting about it later, about a week later when things had calmed down. And I said, well, you were right in front of my wife's office. And she does do obstetrics. And this patient was good-hearted enough. She said, yeah, but it was 5 o'clock, Dr. Jensen. I'm sure your wife wasn't there yet. Anyway, I wanted to name that child Lexus because they drove a Lexus, and that's my favorite car. But they would have named the child Lexi had it been a girl. But it was a boy, so they named it some other. I think it was a car company, though. Okay. Now, any other questions?
I have a question, and that is, we have insurance changes all the time, and I think this year we are changing again. How do you find a good physician?
Typically, am I on, Charlie? Can you hear me okay? Thank you. If you don't know anybody at all, typically, and you're going to another place, like a lot of people move from Minnesota down to Phoenix or something, and they'll ask, what should I do? Do you know any of the docs down in Phoenix? And I say, no, I don't. But what I would do is, at a quiet time of the day, call the emergency room and ask to talk to a nurse. Emergency room nurses will be one of your best referral sources for who should you make as your doctor. A lot of times you can call an emergency room and you can say, I'd just like to talk to a nurse for a moment about selecting a doctor. And most emergency rooms will stand up and say, we'll help you. A nurse will get online. She'll know which doctors have more than their fair share of disasters, which doctors are really good communicators and things like that. So if you're moving, I would do that. If you're not moving statewide, but you're having to move from one network to another, that's definitely, you'd want to talk to the provider that you see now, and you'd want to say, hey, I've got to make a move. I hate to do this. And actually, there's a chapter, the first chapter of my book. Yeah. On the outside, it looks like it's about a fishing lure story, but actually it's more than a fishing lure story, though that part is interesting, I think. But the bottom line is it's all about a network. This patient is now being excluded from being able to see me, and I'd been taking care of him for some time. So he came to me and I said, see this person. But he was absolutely devastated that he had to leave, but that was what had happened with his employer. So I would talk to your present provider, ask about the new network you have to go to. There's a question over here, sir. Go ahead, I can hear you. The question is, what is my medical specialty? Well, perhaps before we answer that question, we should go back and look at my heritage and my ancestry. I'm a Scandinavian mutt. So if you need to see a Norwegian doctor, I'm your guy. If you need to see a Swede, I can do it. And if you want to see a Dane, my last name ends S-E-N. But having said that, my specialty is I'm a family doc, and I did a year's fellowship in plastic surgery in the late 1990s. I saw my wife gain so much joy from doing surgery, and the nice thing about walking into a surgery room is there are no phones, I get to pick the music, and there are no interruptions. So I do a fair amount of plastic surgery in regards to medically indicated procedures. I don't do any cosmetic work, but I do a lot of melanoma, squamous cells, and lumps and bumps and stuff like that.
I'm glad you did, but why did you decide to be a doctor?
Well, there's an old saying, many people can make a straight path crooked, but few can do the opposite. I made a straight path very crooked. I went to dental school because I thought that I wanted to be an orthodontist. I didn't want to be an architect, but I wanted to move blocks, or something like a building block. So I was going to be a tooth guy, but I just didn't like teeth. So I did the logical thing. I went to the seminary. I remember having this discussion with my father, and Dad said, Scott, you're not happy with dental school? He said, you're president of the class. You really dove into this, but now you're leaving it? I said, yeah. He said, well, what do you think about a career in law? Because my father was a lawyer. And I said, gee, Dad, I don't really think that's what I want. He said, well, I would help you. He said, I would help you, pay for the law school test. And I said, well, would you help pay for my seminary tuition? Because I was going to go to the seminary. Well, my father was an atheist, And I said, listen, I'll take the LSAT test, that's the law school test, if you'll pay my tuition next year at the seminary. He said, it's a deal. So I took the LSAT test. Well, I didn't give a hoot, so I did really well. That's the way things work in tests. So he saw my score and he said, Scott, the door's wide open. You can go to law school. I know. I said, but now that I've been through a year of seminary, I don't want to do this anymore. I want to go into medicine. So that's how I became a doctor. It was absolutely the right choice for me. It just took me a while to get there. That's because I'm part Swede. The Dane would have known what to do better, but he was getting pushed out. Medicine is absolutely the best job in the world. I wanted a part-time job because we were empty nesters. And so I had two choices, go to McDonald's or run for the Senate. I made the wrong choice. Yes, sir.
I'd like to hear your perspective as a doctor on what I think is widely recognized that, a huge percentage of our healthcare spending is in the end-of-life stage of life. And I think that's a big social question, but also from a medical care provider, what's your perspective on how to manage that?
To bring the question to everybody, what are my thoughts regarding the amount of dollars we spend in the last 6 months of life? And I'm going to expand on the question a little bit more and ask the question, where are we spending our dollars? So to start with your question, approximately in the last 6 months of life, we spend a third of our healthcare dollars. Approximately a third of our healthcare dollars in the last 6 months of life. At one time, we were spending 50 cents out of every healthcare dollar on people in their last year of life. There has been very little incentive to change that. I could give you a history lesson on hospital and hospital insurance, but another day. But the bottom line is, let's just take this one. If you fall and break your hip and you're over the age of 80, you have a 50% chance of being dead within 3 years. Now, that isn't a comforting thing for the person who just broke their hip. But flip it around. You have a 50% chance of doing okay and living a normal lifespan too. But because of that, we need to deal with the reality of what we're dealing with. If you break your hip and you're in poor health and you're 85 years old, you should realize that there's a good chance that this could be the last chapter of your life. As faith-based people, we should be able to say, as Paul said, "O death, where art thou sting?" We know that this isn't the end. We have to do a better job of integrating who we are, who our faith is, what the likelihood is, what the reality is. Because the fact of the matter is, when we broke our hip, that's a game changer if you're over 85 or 80. Doesn't have to be, but the odds now are stacked differently. We don't have the resources to keep spending money like we are. If in the next 50 years we increase the lifespan from 80 to 100, we're going to have a lot more medical problems. There's other needs on the table too. 25 cents out of every dollar spent on tests and procedures are unnecessary and being ordered by physicians like me because of the fear of being sued. 25%. I was sued in 1990, and I didn't think it was fair because I really tried to abide by the patient's agenda. It didn't work out. When that patient and her family unit became pressed for money, I was a potential source. So a lawsuit took place, it settled out of court, but it changed the way I took care of the presentation that that patient brought to me at 5:30 in the morning that Saturday morning. I had never forgot it. And it cost the system more. Because every time I saw that kind of situation, I ordered this test, this test, and this test. Because I would be damned if I was going to have to go through that again. It changes things. So tort reform is a part of the equation. Excessive intervention in the last 6 months of life is an issue. Low-value services, repeat CAT scans. In the corporate world, if you create a widget, that's a cool thing. You can make some money. But what you really need to do is you need to get the recurring income. So you want to make sure the widget doesn't last forever. Have it break after 5 years so you buy some repairs or buy a new one. Well, in healthcare, we do that. If a radiologist isn't as busy as he or she wants, what's the easiest way in the world to feel better about your financial situation? When you see the CAT scan call it out as negative, but oh, by the way, there is this little shadow in the right lower lobe of the lung, and we don't know whether or not it's significant. So we're going to follow the Fleischmann protocol, which means that we don't want to operate on your lungs. Heavens to Betsy, it's probably nothing, but it could be something. So we're going to have a CAT scan 3 months, 6 months, 12 months, 18 months, and 24 months. And if after 24 months all those CAT scans are negative, we'll call you clear and it's not a problem because it's not growing. That makes sense. But every one of those CAT scans is another $1,000. That's recurring income. Let's do this. First CAT scan gets paid standard rate. Next one, 50% of that. Next one, 50% of that. Next one, 50%. By the time we get to the 2-year CAT scan, the radiologist is getting 10 cents on the dollar, and he or she is going to be motivated to rethink this. Do we really need to do it that way? We got to get frank about this.
Oh,
Anything else?
can we hear a little bit about how you set up your clinic called Catalyst in Watertown? How do you deal with some of what you're talking about?
My wife and I started a clinic 17 years ago, and we call it Catalyst Clinic, and the reason we called that was because I woke up at 5 o'clock in the morning frustrated with God for not answering my prayers because I wanted to have a name for this. And so I woke up at 5 o'clock in the morning. Mary and I had already dismissed a couple other names that had been suggested to us. One was my choice was the Unclinic, because right then there was an ad campaign on the Uncola. So I thought it'd be an Unclinic because I wanted the clinic to be different. My wife's a veterinarian, and I do a lot of well care, so some people had said that we should call it Pets and Pelvis, and that didn't go. So I woke up at 5 o'clock in the morning saying, God, all I want to do is I want to participate in a place where it's just a catalyst for patients to get the health care they want, where patients can champion their own needs. So I played it back in my mind, and all of a sudden, Catalyst seemed right. I woke up Mary, I bounced it off her. She said, I like it, and I'll go back to bed. About 3 days later, I'm meeting with my accountant, a guy you may or may not have met, a guy named Charlie. He had filled out all the paperwork so I could become incorporated, but the numbskull had put down catatonic, so I'd signed all these papers. So I had just started a new clinic, the Catatonic Clinic, and all of a sudden I look at it and I said, Charlie, you numbskull, you can't be doing this. Oh, he said, I pulled out the wrong file, and he pulls out the right file. So I haven't forgiven him for that, but I'm getting closer and closer each passing year. At our clinic, we don't want it to feel like a clinic. So every room has a theme. We've got the garden room, we've got the golf room, we've got the tractor room, we've got the MASH 4077 room. But when you come in, we don't want it to smell like a doctor's office. We don't want it to feel like a doctor's office. We want it to feel like a place that you can be comfortable, your blood pressure can drop, and you know that you're in charge. I tell patients over and over again, if Tiger Woods is in this room and there's a caddy in this room, I'm not Tiger, you are. I'm the caddy. I'm going to hand you the 7-iron, remind you that the wind is in your face and that there's water on your right, but you've got to hit the ball on the green. And that's the way it should be. If patients come to me and dump their bucket in my lap and say, there, doc, you take care of me, tell me what to do, I say, find another doc. I'm not interested. This is a partnership, and you're in charge. And if you can't handle that, neither can I. Other questions? Yes, ma'am. The question is, what do I hope to accomplish in life? No, it wasn't really. I was going to say as many grandchildren as possible. 16 months ago, my wife and I had 0 grandchildren. We now have 4. We're deeply blessed. I have this thing going on in politics. I ran for politics because I thought I could maybe have a voice in the health science area. There were no doctors in the Senate or the House at the time. I do run as a Republican, but I like to think of myself as somewhat of a centrist. In the coming year, I talked to the Senate Majority Leader yesterday. I have 3 big issues this time. I want to blow the lid off of gag clauses and hidden secrecies. I want transparency at all levels so that patients know. Right now, we have a law in the books that if you go in to see a pharmacist and I give you amoxicillin, you use your insurance card, the amoxicillin may cost you $30. The pharmacist cannot tell you that if you paid cash, it would only be $8. That's silly. We have to be transparent. Second thing is we've got to go after the pharmaceuticals, and the only way you can go after them is be ready for the onslaught in the 11th hour because they will come out with all their guns blazing. So if you want to get reelected and you want their dollars, you can't take that fight on. I don't want to get reelected, even if I end up running again. You should always vote for people who don't want to be there. I don't want to be reelected, so I don't care if the pharmaceuticals don't like me, but we're going to get this done. We cannot let them gouge. Right now, we've gone from 10% of the healthcare costs in pharmacy to almost 30%. We used to spend $1 out of every $3 on people in the hospital. That's dropped from 33% down to 20%. Literally pharmacy is a parasite on our system, and you're taking a lot of drugs you probably don't need to be on. And the third thing I want to do is we have 5% of people in Minnesota not covered. 95% have some form of coverage. That 5% of people, I wouldn't want to be one of them. I wouldn't want my neighbor, my friend, or my family to be uninsured. We all deserve to have some basic package. We got to get that 5% over the goal line so everybody's covered. Those are my goals. Yes, ma'am.
I actually work in the healthcare field. I'm a nurse diabetes educator, and you kind of answered my question, but one of the most challenging things, especially in diabetes, so much is up to the patient, you know? I mean, certainly with type 2. And how do you motivate patients to, you know, in a way, own
The question is, type 2 diabetes, epidemic, an epidemic of type 2 diabetes. And so much of what a type 2 diabetic will be served by is lifestyle changes. I can't do the lifestyle changes, so how do we motivate people? I'm going to go back to that strong rope. Relate, own, personalize, expand. I tell my patients, say I've got someone who comes in, they're type 2 diabetic, and smoking a pack of cigarettes a day. Usually my parting shot with them will be this. I'm not going to give you a lecture that tobacco is not good for you. If you don't know that, you've been living in a hole that I can't help you from. But I'm here. And if you want to quit or cut down, just call us. Don't call in. Don't come in. Don't waste your time or money. You just call us on the phone. We'll do whatever we can because there's nothing magic about trying to help you quit smoking. We'll set you up with a therapist. We'll call in the medicine by phone. We won't charge you. We'll try to get you coupons so that the Chantix is paid for or the Nicoderm is paid for. But we have to work and negotiate with people. I mean, you don't win arguments with your spouse by just dictating or guilting or bullying. You do it by talking, negotiating, and that's the same thing you do with type 2 diabetics. I have some type 2 diabetics that are perfectly content being type 2 diabetics, uncontrolled, smoking, and obese without exercise. And some of them, they're 92 years old and healthier than I am. So we don't have all the answers. Here's a really dirty little secret. We're causing some of the diabetes. Lipitor actually causes diabetes. And here's what the medical literature says. If I put a patient with high cholesterol, I put them on Lipitor, and they don't have diabetes, and they develop diabetes on the Lipitor, my next response is to not be to stop the Lipitor, but to increase it, because now that they have diabetes, I'm supposed to lower their cholesterol further. Now, how counterintuitive is that? This is what we do, and this is why you are the champion of your own healthcare.
And
Type 2
that-
diabetes, you've got to negotiate with people. You've got to work with them and say, hey, how can we do this together? That's all.
And that story is one in the book, and I encourage you to pick up the book at the back at the table. Mary will be there. Thank you so much. This has been really eye-opening, and I'm glad that we could hear more about you personally.
Thank you.
Thank you.
Thank you. Thank you.